In this lecture, we're going to talk about fine touch and proprioception. Sensory systems similar to gross touch, but there are some critical differences that will confuse you until you get it, and then you'll be fine. But the bottom line is we still have a receptor out in the skin for fine touch. We still have a dorsal root ganglion neuron projecting into the spinal cord. What's different about fine touch and proprioception is that there's no synapse in the spinal cord. These neurons travel in the dorsal columns all the way up to the medulla in the brainstem before they synapse. So again, it's a 3-neuron chain with the dorsal root ganglion neuron out here. But the second neuron is where things get different. So it travels up and synapses in the medulla, which is why this has an asterisk. And then neuron 3, again, is still going to be in the thalamus before it goes to primary sensory cortex. So in the next section, we'll talk about all of the different pieces of this 3-neuron chain, where it's similar to gross touch and where it's different from gross touch. In this segment, we'll talk about the individual neurons that make up the 3-neuron chain for fine touch and proprioception. So neuron number 1, of course, as always, lives in the DRG. Its peripheral process is going to be in the skin, and it's going to project a central process into the dorsal horn. It doesn't synapse here. That's the big thing to remember, and it doesn't cross the midline. So it passes through here. It may give some information to some of the neurons around here via what we call an axon collateral, but that's not its main synapse. It's going to ascend on the same side in the dorsal column. Okay? The dorsal columns are divided. They have a regional specificity. So the fasciculus gracilis is here, and the fasciculus cuneatus is here. Gracilis is going to be concerned, it's going to be carrying fibers from your lower extremity and part of your abdomen. Okay, the way I remember gracilis is that there's a big muscle in my thigh called the gracilis muscle, and so I always put gracilis and gracilis together. The fasciculus cuneatus is over here. It's a little more lateral because if those axons that are coming from the arm are going to enter on their way up after the ones in your leg have entered. Okay, and the way I remember cuneatus as being my upper extremity and my thorax is cuneatus kind of goes with cuticles, which are around your fingernails, so it's upper extremity. You'll figure out a way to remember it for yourself, I'm sure. The second neuron in the chain is in the medulla oblongata, and there is a nucleus. There's a gracilis nucleus and a cuneatus nucleus, and that is where all of the axons from the fasciculus gracilis are going to synapse here, and the axons from the fasciculus cuneatus are going to synapse in the cuneate nucleus. So you have 2 divisions of that dorsal column, gracilis for the leg, cuneatus for the hand or arm, and you have 2 nuclei, the nucleus gracilis and the nucleus cuneatus, where those tracks are going to end. This neuron is equivalent to that neuron in the dorsal horn of your spinal cord for gross touch. So it's going to cross the midline. So its axon crosses and then ascends. We call these fibers, as they're crossing, the arcuate fibers. Once once the arcuate fibers have crossed the midline, we call this band of fibers that's ascending the medial lemniscus. I can't even spell. So let me clear this and draw it a little more neatly. There's a nucleus, nucleus cuneatus, nucleus gracilis, where their specific tracts end. Neurons cross the midline. These are the arcuate fibers. I have to remind you that a lot of these fiber tracts and things were named before they knew what they were doing. Not that the anatomists didn't know what they were doing, but they didn't know exactly where the fibers were coming from and where they were going to. So they named them arcuate because it's a curve, it's an arc. They then ascend in the medial lemniscus. And this is so the second neuron here is the one again that's going to talk to the neuron in the thalamus. So fine touch and proprioception, third neuron in the chain, just like gross touch, is going to be in the thalamus. And the neuron in the thalamus then projects to primary somatosensory cortex. And again, that is your post-central gyrus. So in the next sections, we'll go through and draw this pathway a couple of more times just to solidify it. And then at the end, we'll kind of summarize what the big differences are between gross touch and fine touch, so that you get those straight in your mind, because they're important diagnostically, and we'll talk about that a little bit at the end. So in this slide and the next, what we're going to do is draw the pathway for fine touch and proprioception. And then as we're going, we'll kind of compare and contrast with gross touch, and then we'll talk a little bit about some of these differences and why they're important. So to begin, so fine touch, let me see. Here's a penny, and here's a dime. Dimes are rough, pennies are smooth. You can feel the difference between a penny and a dime because of your fine touch sense. Proprioception, again, is knowing where your limbs are in space, and that travels with fine touch. So there's a dorsal root, so you have a finger, and a thumb, and well, you know me and my drawing. So anyway, so here's the dorsal root ganglion neuron, which is number 1 in the chain. And it enters the dorsal horn. It may kind of give a sidebar chat with some of the neurons here, but for the most part, it's not its biggest synapse, and it travels in this dorsal horn, in the dorsal columns. If it's from the leg, it is in the gracilis. If it's from the arm, it's in the cuneatus. It comes up to the medulla oblongata and synapses appropriately either in the gracilis nucleus or the cuneatus nucleus, okay, based on whether it was traveling in which of these parts of the dorsal columns. These neurons cross the midline, and now this fiber tract is called the medial lemniscus. These fibers of these secondary neurons that have crossed the midline ascend to the thalamus, where they synapse again on a thalamic neuron, which goes to the primary somatosensory cortex. So what I hope you do is get a piece of paper. You don't have to draw in pretty spinal cords. You can just draw boxes or circles or whatever you want to draw. And practice drawing fine touch and proprioception, and practice drawing gross touch, so you remember where the second neuron in the chain crosses. Because remember, this first neuron is very simple. It's always going to be the DRG neuron. The third neuron is also simple. It's always going to be the thalamus neuron. It's this second neuron that can cause some consternation and some confusion. But once you get that down, you've got the sensory system down. So in the next slide, we're going to go over it in boxes, because boxes are even easier than brains. So again, another way of, another schema to look at fine touch and proprioception is to remember that there's a stimulus. The first neuron is in the dorsal root ganglion. That dorsal root ganglion neuron then goes into the spinal cord and goes through either the fasciculus cuneatus or the fasciculus gracilis. It then synapses in the medulla in the nucleus cuneatus or the nucleus gracilis. These are the second order neurons. They cross the midline, and we call them arcuate fibers when they cross the midline, and then they ascend or go up towards the brain via the medial lemniscus. They synapse in the thalamus, and then that third neuron projects to the somatosensory cortex, where it comes to perception. So again, the first neuron and the third neuron are where they always are, in the DRG and in the thalamus. The second neuron for gross touch is going to be in the spinal cord, and its axons cross. For fine touch and proprioception, the second neuron is in the medulla, and those are the neurons that cross. So it's always the second neuron that crosses the midline. So to summarize, again, how many neurons does it take to relay fine touch and proprioception to the primary sensory cortex? Where are these neurons located? Which of the axons cross the midline? Where does that axon cross the midline? And then where does this axon travel as it ascends towards the brain? So where does it travel in the spinal cord? Where does it travel in the brainstem? Once you understand these things, you'll be ready for the assessment. Practice drawing. Doesn't matter how pretty or how ugly your own illustrations are, but once you draw it, you'll understand it, and you'll be ready for the assessment.
Hi, my name is Nico, and this is Christina, and we're from the University of Michigan. In this video, we'll be discussing a neurological exam of sensation, as well as a little bit of motor exam as well. So the sensory exam is useful in two respects. One, as you know, pain and gross touch travel differently within the spinal cord than fine touch and vibration. So if you detect an abnormality, you can localize it within the spinal cord depending on the lesion and its findings. Second is in many neurodegenerative diseases, the disease will move from distal to proximal, and by assessing where exactly it has progressed, we can determine the severity of the disease and its progression through its course. So I'll start briefly with the progression of neurodegenerative diseases. So when you do that, so I'll have you hold out your hands. It's important to test at the most distal site you can. So if I test here at the palm and everything's normal, that is only going to be indicative of here and proximal, but I don't know how things are going distally. So I'm going to test at the fingertips. So if I had a tuning fork, I would shake it and then place it on her finger and ask if she can feel it vibrating. And then I would also use a sharp pin or something and of the sort, and then place it on another finger and ask if she feels the sharp end or the dull end. Of course, I would have to do this with her eyes closed so that she couldn't just see it. She would have to feel it. Using that, if, for example, she could feel the pin, the sharp pin on her pinky on her left hand, but she couldn't feel the tuning fork, that would help me localize where in the spinal cord the lesion was. So we talked briefly about proximal and distal sensation with regard to neurodegenerative diseases, as well as pain and fine touch. And now briefly we'll demonstrate a short motor exam. So I would have her hold her arms out like this, and now push up against my hands. Okay, excellent. And so I can feel her pushing equally on both sides, so that would be a healthy or negative motor exam. And I would do that for all of the different muscles, isolating them so I could do arm flexion, forearm flexion, extension, etc. So this has been a brief overview of the sensation and motor neuro exam.